Hello, everyone. My name is Natalia Saukova, and I'm an International Scientific Officer of IIDS. It is my honor and pleasure to welcome Dr. Ahmed Youssef, who graduated in Egypt and is currently a PhD student in Germany. He's going to present you management of dental trauma and permanent dentition today. So I hope that you had a great weekend and that you're ready to hear this amazing welcome, Doctor.
Hello, Natalia. Good afternoon, everyone. Good evening or good morning, depending on where are you in this world. Happy Eid for the people who are celebrating the Eid today or tomorrow. Today, we will speak about the management of dental trauma, mainly in permanent dentition. And I will not go into the surgical aspect of managing of dental trauma. It will be confined to the restorative aspect. The whole presentation is following the International Association of Dental Traumatology recommendations. So, yeah, let's start. So, the traumatic dental injuries, it's important to know why or how to manage the traumatic dental injuries, because the traumatic dental injuries occur with a great frequency, especially in the preschool and school-age children. Also, young adults can be affected by traumatic dental injuries, and the traumatic dental injuries comprise 5% of all injuries for which the people are seeking a treatment. In a 12-year review of literature, it reports that 25% of all school children experience dental trauma, and 33% of adults have experienced dental trauma to permanent dentition, with the majority of injuries that occur before the age of 19. In the literature, when we look, we find out that the traumatic dental injuries has a prevalence ranging from 2.4 till 58.6. So it's not a rare condition. It happens, and it can be something that you see in weekly basis, if not on daily basis in your clinic. So when we speak about the etiology of dental trauma, there are many factors that makes dental trauma happen, or there are many reasons for the dental trauma. First, the oral predisposing factor depends on the occlusion. In patients with increased overjet and inadequate lip coverage, it's found that they are more liable to traumatic dental injuries. According to Oliveira, in children younger than 5 years of age, the anterior open bite results in twice as many traumatic dental injuries when compared to the normal occlusion controls. And also, the Swedish Council of Technology concluded that there is an increased risk of traumatic dental injuries to the upper front teeth if the patient has an increased overjet with protrusion in combination with inadequate lip coverage. The other factors that can affect the happening of dental trauma is the behavior of the children. It's found out that risk-taking children and hyperactive children are more liable to traumatic dental injuries when they are compared to the more sedimentary children. There is also some studies that inspected the effect of obesity on the behavior of children and on the incidence of traumatic dental injuries, and some publications reported that traumatic dental injuries occur with more incidence in obese children, but there are also other evidences that say that it's not true. Another reason for occurrence of traumatic dental injuries is unintentionally, like when someone falls or when some is being hit or struck by an object. It can result in a trauma for the teeth and the supporting structures. Also, illness and physical limitations can affect the incidence of traumatic dental injuries. For example, in epileptic patients, it's 52%. It's found out that traumatic dental injuries occur with 50 up to 52% in during the seizures. Also, patients with cerebral palsy, it's found out that they are 57% more liable to traumatic dental injuries um, when they are compared to the healthy controls. Another factor can be the learning difficulties due to lack of motor coordination or concomitant epilepsy. The lack of motor coordination can result in falls, and due to the falls, some traumatic dental injuries can happen. Also, hearing or visual impairment can result in traumatic dental injuries to happen for these children or young adults. And yeah, there is an observation found out that the people with hearing impairment are more um, have higher tendency for traumatic dental injuries than people with visual impairments, because people with visual impairment um, are more cautious and more careful when they are moving or they are doing an outside activities. Another factor is inappropriate use of teeth. For example, to use teeth to open the hair clips or fix equipment, or when you are outside in a party and you can't find the bottle opener, so you start opening your beer bottle with the teeth. You can um, break, you can have a traumatic dental injury, a fracture of the crown or something, because you just didn't look for 10 seconds to find the beer opener, or you didn't use something else to open the beer. Some other reasons for occurrence of traumatic dental injuries is sport injuries, and sport injuries is one of the highest reasons for the occurrence of traumatic dental injuries. It results in 32.2% of all the traumatic dental injuries reported in some populations. Also, traffic accidents can result in traumatic dental injuries. And lastly, the physical abuse and assaults can cause traumatic dental injuries, and that differs widely all over the world. Some parts of the globe have statistically significant less reported case of physical abuse and traumatic dental injuries due to physical abuse than other parts of the world. So when we look about the classification of traumatic dental injuries, we will find out that there are many classifications. The first was by Ellis, and it was kind of a simple classification. It classified the injuries into a simple fracture of the crown involving little or no dentine, and then another type is extensive fracture involving dentine, extensive fracture involving dentine and bulb, and the traumatized tooth that becomes non-vital with or without loss of crown structure, total tooth loss, and fracture of the root. It's started to get more detailed until the forms that we follow now, which is introduced by Anderson, and it was a modification to the World Health Organization classification of traumatic dental injuries. And this one we are going to describe in details, and we will speak about the management, the clinical management of these cases. So let's start. It's as I said, we will speak mainly and nearly only about the permanent dentition today, and not the primary dentition. So the first type of traumatic dental injuries that can be seen, and the simplest one, is infraction injury. The infraction is an incomplete fracture or a crack of the enamel without loss of tooth structure. Clinically, you will not see any abnormal anatomy. You will just see a crazed line in the teeth, and you can best see it with a transillumination. If you place a source of light behind the affected tooth or affected teeth, you can see clearly the crazed lines. Like in the picture here, this is a crack. This is actually in my tooth, and you can see it clearly when you put a source of light behind the tooth. Radiographically, it appears normal. You don't see any crack lines or anything on the radiograph, and usually no treatment is needed. But in case of a marked infraction, when you go with the probe and you feel that there is a step, or you feel that there is a difference between the two parts, it's advised that you restore this crack with resin infiltration. You can use flowable composite for it, with a self-etch adhesive or something. And usually the prognosis is very good for such cases, and the complications are unusual to happen. Like I said, I have this crack since over 14 years or something, and till now, thankfully, I didn't have any complications from it. The second type is uncomplicated crown fracture. And the first form of uncomplicated crown fracture is enamel fracture. If you see here in the picture, this is a loss of enamel without inclusion of dentine in the lost part. Can you hear me well now? So for the clinical picture in teeth with enamel fracture, you will see a loss of enamel, but you will not see any exposed dentine. You will find the patient not complaining of any tenderness in the tooth or any sensitivity. The mobility is normal, and if you carry on a sensitivity test, it will show positive results. So for the radiographic findings, you may see enamel loss visible in the X-ray. It's of course depending on how big is this fracture part. But if the fractured part is like here in the picture, very small, most probably you will not be able to see it on the X-ray. Usually the treatment is bonding of the fractured part if you can find it. And if you cannot, then a composite restoration or contouring of the tooth is also an alternative to do. An important notice for you is that when a patient comes with a fractured crown, you should ask him how this happened, and you should examine the lips and the cheek, because you may find the fractured part in the lips. In order to be sure, you can take an X-ray for the lip or the cheek, and if the fractured part is in the lip, you can rebond it. Usually, the prognosis for such cases is good. Yeah, the teeth can be asymptomatic, has a positive response to pulp testing. If it was an immature teeth, then it will show continuing root development, and that's a favorable outcomes. But can have if you have a patient which came with an enamel fracture, but the patient says that he feels tenderness, then you should assess or you can find out that the whole tooth fragment is moving. Then you should assess the situation, because it can be another type of injury. As we will know later, it may be a crown fracture or enamel fracture associated with subluxation or luxation injury. The second type of uncomplicated crown fracture is enamel dentine fracture. It's called uncomplicated because the pulp is not affected by this fracture line. The fracture line is not reaching to the pulp. It's perfectly confined to enamel and dentine. And for this, you will see enamel and dentine loss. You will not see any pulp exposure. The patient will not report any tenderness, and as I said, if the patient reports tenderness, then most probably it's associated with a luxation injury. You can find the mobility of the tooth within the normal range. The sensitivity test will result in result, like the patient will react to cold test or electric pulp testing, and the percussion test, the patient will give a negative. You will have a negative result for the percussion test. The patient will not report any tenderness on tapping on or percussion on the tooth. In the radiographs, you will see an enamel and dentine loss visible on the X-rays. And for the treatment, bonding of the fractured part can be done. Composite restoration or ceramic bonded restorations are also an option. If it was the case that you have the fracture very near to the pulp, you may see a pulp shadow. You may see a pink color without bleeding. So please don't get the probe and start to examine this area in order to make sure that there is no pulp exposure. Please, with a very small endophile, size 6 or 8, and start carefully examining this area. But if you get the probe and you apply 4, and if you have a very thin dentine bridge, less than 0.5 millimeter, you most probably will break this dentine bridge, and you will result in a complicated crown fracture, and you will have to deal with the exposed pulp before doing any restorative treatment. So please use an ISO 6 or ISO 8 endophile to examine the area and to be sure that there is no pulp exposure in case you see a pink shadow of the pulp. Usually the prognosis of such cases depend on the extent of the dentine exposure, but usually it's showing a good prognosis, and you can follow up these cases for 6 to 8 weeks. You do the sensitivity testing, you examine it with the percussion, and after 1 year you can do another radiograph to make sure that there is no signs of periapical pathology or any signs of pulp necrosis. The third type of traumatic dental injuries is a complicated crown fracture. So in this crown fracture, the enamel and dentine fracture reaches the pulp. So you have an exposed pulp in this case. The exposed pulp in this case is not due to caries, so it's mostly not infected. So this will determine how will you treat this type of fractures later. So clinically, you will see a tooth that has loss in enamel and dentine, and you can clearly see a pulp exposure. It will not be tender to percussion. It will not be tender to palpation. It will have a normal mobility, and sensitivity will be positive. If you find any other signs like pain during percussion or something, then maybe it's also associated with a luxation injury or a root fracture as well. Radiographically, you will only see enamel and dentine loss, and you will not see any signs of root fracture or luxation injuries. For the treatment of such cases, there can be, as we said, this traumatic dental injuries occur to young patients. So it can be the case that your patient is having an immature tooth, or the root formation is not completed. So in this case, treatment of choice is a vital pulp therapy, and it can be done either by pulp capping, direct pulp capping, or partial pulpotomy using MTA or Biodent-D. If your patient had a completed root formation, then you can do a normal root canal treatment, and then you finish it, and then you do a corona restoration, either with composite restoration or later on with a bonded ceramic restoration if the patient is demanding high aesthetic. But you can also reach high aesthetic restoration with composite resins, like in this case, as you can see. And usually it's stable for up to 7 years or even more if the patient is taking care of cleaning the restoration and cleaning the tooth in general, and you have used the right type of composite which has high aesthetic properties and high polishability and not using a composite restoration that has a fillers which is very large in size that can be lost easily, and it result in discoloration easily. For the prognosis of teeth with complicated crown fracture, the prognosis is affected by the stage of root development. It's also affected by the periodontal state and time of the time from pulp exposure to the start of the treatment. So if the patient has waited like a week with where the dental pulp is in direct contact with the oral flora bacteria and the patient is having an open apex, and you most probably, instead of dealing with a completely sterile dental pulp or a minimally infected dental pulp, you will have a dental pulp full of bacteria that can result in a high probability of pulp necrosis later on. So for such cases, you just try to do the pulp capping, partial pulpotomy if it was, and you follow up the tooth for up to 1 year. And if there is any signs of developing apical pathosis or loss of sensitivity or any other signs and symptoms, swelling, for example, or something, then you will need to do a definitive root canal treatment, even if the patient had an open apex. And in this case, you will either go to the revascularization protocol or to the apical plug, depending on the length of the root and depending on the state of the periodontal ligament. For the partial pulpotomy, yeah, it's you can, after isolating the teeth, you remove 2 millimeter of the pulp tissue by a very small 330 Bayer or 245, but you don't go the full length with the 245. You go half the length of the 245 Bayer. And then with a pelletum or a cotton pellet, you stop the bleeding. It's important to stop the bleeding before applying your calcium hydroxide or biodentine or MTA, your pulp capping agent, or your materials that you will be using to seal the pulp. And over the MTA or biodentine, you can use a very, very little amount, like a 1 millimeter or 2 millimeter thickness of glass ionomer, and then you can build up the tooth with a composite restoration, and you follow up the tooth. If everything went fine, then you had your success. If any signs and symptoms that can say that the patient is having a developing pulpal or apical pathology, like apical periodontitis or necrosis of the dental pulp, then you would have to do a root canal treatment. So that was crown fractures, but what if the fracture is reaching the root as well? So in this case, it's also, you can have an uncomplicated crown root fracture. In this case, you will see the crown fracture extending below the gingival margin, and you will see the coronal fragment mobile, and the percussion test will be positive. When you tap on the tooth, the patient will report pain, but this is not because apical pathology. This is because that the broken part is moving in here and it's peaking the periodontium and the gingiva in here, and that's why the patient reports some sensitivity when you do the percussion test. It's not because that there is an apical pathology. So please be careful when diagnosing such cases, because maybe this tooth is having a healthy pulp and the percussion test is giving a positive result because of the extension of the broken part to the root, and you diagnose it as a necrotic pulp or an apical periodontitis, and you do a root canal treatment for this case while it's not needed. For the radiograph, you need to do an ortho grade radiograph, like a 90-degree radiograph, and also an eccentric radiograph, because the apical extension of the fracture is usually not visible. You may also see radiolucent oblique lines that represent the crown and root fracture. And if you can do a cone beam CT, you will clearly see in the axial cut the extent of the fracture. For the prognosis, it depends on the level of the fracture. Fractures extending significantly below the gingival margin may not be restorable. So if you have a fracture that ends up in here, like it's not including the bulb, but it ends up in here, when you remove this part, then you will not be able to restore this tooth. For the treatment options for these cases, as an emergency treatment, you temporarily stabilize the loose segment to the adjacent teeth with a composite, like you splint the broken part to the adjacent teeth. And as a definitive treatment, you can do one of the following. You, depending on the extension of the broken part, you may remove the coronal crown root fragment, and then you restore the apical fragment. This is called the apical fragment. The remaining of the tooth is called the apical fragment, and this is called the coronal fragment. So you remove the coronal fragment and you restore the apical fragment exposed above the gingiva with a crown or a bonded ceramic restoration or a direct composite restoration. If the extension of the fracture was nearly to the bone level or below the bone level, then you will need a gingivectomy or a surgical crown lengthening to do a restoration over this. If the broken part was very big that it will not be that the remaining tooth structure is not enough to be holding a crown on its own, then in this case you will have to do an intentional root canal treatment to have a post-retained crown. But if you have a tooth with open apex, this is contraindicated. Then you can remove the coronal segment. This is contraindicated. Let me continue. I'm sorry, I will have to continue this. This is contraindicated to do an intentional root canal treatment for an immature teeth because this tooth does not have the full length of the root now. And if you do an intentional root canal treatment, then you will have you will stop the continuation of the root formation, and this will result in a tooth with a short root that can be weak and not provide enough support for the crown that you want to put on this tooth. So if you have an immature tooth that has a crown root fracture, you may consider remove the coronal segment and do an orthodontic extrusion of the remaining root, and then you do a crown over this tooth, or you restore this tooth like temporarily with a composite restoration until the complete formation of the root. And then you either do an orthodontic extrusion or a surgical repositioning, and then you place a definitive restoration, a crown or a If the fracture is lingual, then you place a lingual veneer. If the fracture is buccal, then you place a buccal veneer, and that would be your definitive restoration later on. But and you can also extract this tooth and place an implant or make a bridge, but that is not suitable for patients less than 18 years. And yeah, the other options are more realistic. However, it takes more time, but they save the tooth and they save the pulp in case of young patients with immature teeth. So yeah, I want to make sure that everything is working fine. Please give me feedback if everything is okay.
Yes, everything is working perfectly. We can hear you well. You can go ahead.
Okay. Can you please close the mic? Whoever opened his mic. Hello. Hello. Can you hear me? So, oh, good. So now it's better. Okay. So now we will talk about the complicated crown root fracture. So by definition, it's a fracture that involves enamel, dentine, cementum, and it's also exposing the bulb. The clinical picture of such a fracture, you will see a crown fracture extending below the gingival margin. The coronal fragment will be mobile, the percussion test will be positive, and the sensitivity will depend on the time between the injury and seeking the treatment. Sometimes you have negative sensitivity response due to the long time needed before seeking the treatment and the start of necrotization of dental pulp, so you don't have a positive pulp response. Um, I'm not sure if everything is going fine. Can you, Natalia, can you please open the mic and tell me if everything is going okay? Hello? Hello, everyone? Hello, can you hear me? Hello? 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 Can you hear me? Hello? Hello?
Hello, please go ahead. We apologize for internet disconnect for a second, and we can now continue.
Okay, so please let me know till when. Okay, so I can continue from complicated crown root fracture, or did you miss something?
No, you can continue with that. That would be perfect. Thank you.
Okay, sorry for the disturbance. So, for the complicated crown root fracture, for the radiographic findings, you will see the apical extension of the fracture is usually not visible like in the uncomplicated crown root fracture. And you can see the extension of the fracture with the preapical, occlusal, and eccentric radiographs. You may see a radiolucent oblique lines that compromise the fracture, and if you can have a CPCT image, you will be able to see the whole extension of the fracture, most probably. The prognosis is depending on the level of the fracture, and as a uncomplicated fracture, the fracture is extending significantly below the gingival margin, like till apical third or something, is very hard to treat and to restore. Um, for the treatment of such cases, like the uncomplicated fractures, the emergency treatment is to splint the broken part into the adjacent teeth, and for a definitive treatment, you you can do a pulp capping or a partial pulpotomy in immature teeth. In other words, you do a vital pulp therapy, you don't go for a root canal treatment. And you follow up the case, and if everything is fine, then the root will continue to develop. And if you find out the tooth is having or is developing a negative sensitivity testing and it shows signs and symptoms of pulp necrosis, then you will have to do a root canal treatment. In patients with open apex where you cannot do a regular or a normal root canal treatment, you will have to do an apical plug, and then restore the tooth with a fiber post and a crown. Or you will have to refer it to an endodontist who can do the apical plug for you. Um, Also, you may remove the coronal fragment and do a root canal treatment and post-return the crown. It can be preceded by gingivectomy and sometimes surgical crown lengthening. That's in case of mature teeth with mature root formation, and yeah, where you can do straightforward root canal treatment. You will do a root canal treatment, you will place a post, you will build a core, and then you will crown the tooth. You may also remove the coronal segment, do a root canal treatment and extrusion of the remaining root, and then post and retain the crown. And you may also do a surgical repositioning of the root. In this surgical repositioning of the root, you use periotomes and you atraumatically as possible extract this portion of the tooth and place it in a higher position, splint it for 2 weeks, and then remove the splint. Finish your root canal treatment, put your post, and then place your crown. Also, you may extract the remaining part of the tooth or do a bridge. The next form of traumatic dental injury is the root fracture. For the root fracture, it's dentine and cementum fracture, and it usually, like 99% of the cases, involves pulp. The coronal segment may be mobile and may be displaced. The percussion test will have a positive result. You may see gingival sulcus bleeding, especially if the root fracture was more near to the cervical third. And the sensitivity test can be negative because of a transient or a permanent pulp damage that can happen. You should monitor the state of the pulp in order to decide your treatments. For the treatment, you will need to reposition the tooth as soon as possible, and if possible to reposition the tooth up to 1 millimeter difference between the two fragments, then this would be great. You have to do a radiograph to check the new position after repositioning your fragment. You should splint the broken tooth into the neighboring teeth with using a flexible splint, and I will discuss at the end of the presentation what are the types of splints and what are the flexible splints and why do you have to use a flexible splints. You splint the tooth for 4 weeks, but if your fracture is more cervical, then you may need to splint the tooth for complete 4 months, up to 4 months. You follow up your case And if at any time the tooth develop signs and symptoms of pulp pathology or periapical pathology, then you will have to do a root canal treatment. And in case of teeth with open apex, you will have to place an apical plug with an MTA and fill the rest of the canal with catapersia, or you can use a fiber post bonded into the canal walls to use it as a permanent fixation method of the fractured parts of the tooth. A very important thing to notice while diagnosing your cases. Here you see on the left side, that's a clear root fracture. But what you see on the right side, that's not a tooth, that's not a root fracture, that's only the shadow of the nose. And it results in a different radio opacity, and the different level of radio opacity can be misinterpreted as a fracture, but in this case it's not a fracture. You have to look on the continuity of the lamina dura. You will see here the lamina dura is continuous, but if you trace it here, you will see it's not continuous in here and in here. You follow up the case usually after 8 weeks, after 6 months another time, after 1 year, after 3 years, after 5 years, maybe once per year after the first year, just to make sure that everything is going fine. And if at any time uh, signs of any external resorption or any periapical pathosis happen, you can take the right decision by doing the right treatment. For the prognosis of the root fracture, there are some factors that affect the healing, and it's found out that the young age, immature root formation, the positive pulp sensitivity at the time of injury, and approximating the dislocation within 1 millimeter have been found to be advantageous to both the pulpal healing and the hard tissue repair of the fracture. And a study by Anderson stated that up to 78% with root fracture showed healing of the fracture either by hard tissue, fibrous, or osseous tissue, with no difference between the fracture positions on the root. So it's advised to just follow the same protocol regardless where the fracture location is. In case of cervical fractures, the only difference is that you leave the tooth splinted for longer time, up to 4 months, because in this case it has no enough support, because only like 2 or 3 millimeters are under the bone level, and it needs to have an advanced uh, stage of healing before you can remove the splint. You of course will assess the mobility, you will assess the sensitivity, you will assess the percussion testing, and based on this you will decide to remove the splint, but you can leave it up to 4 months. So now we will have a new uh, form of traumatic dental injuries. It's not severe like the fractures. It's a little bit more simple, and it's called concussion. And first type of the luxation injuries. So, for the concussion, what's the meaning of concussion injury? It's an injury of the tooth supporting structure without abnormal loosening or displacement of the tooth. The clinical picture, you will have a tooth with which is tender to palpation and tender to percussion. It's not because of an apical pathosis. It's not because of pulp necrosis. It's now at this moment is because of the inflammation, because of the trauma that affected the supporting structure, the periodontal ligament. There will be no gingival sulcus bleeding. The mobility will be normal, and the sensitivity test will show a positive result. However, the tooth will be tender. Radiographically, you will not see any abnormality. You will see the tooth normal in place. You will not see any enlargement in the periodontal membrane space. Everything will be fine. You do not need to do any treatment, and you will have to follow up the case. If the tooth showed up any signs of pulp necrosis later or developing periapical pathology, periapical periodontitis or periapical abscess, then you would have to do a root canal treatment. For the prognosis, the pulp necrosis may occur due to the injury of the associated blood vessels at the apex. It's not something that's rarely happening. No, it happens with a high percentage in such injuries. You follow up the case for 4 weeks, 6 to 8 weeks, 6 months, 1 year, and if you find at any point there is a change in the state of the first examination or the later examinations, then you would have to do a root canal treatment. And these type of injuries can be also associated with an enamel fracture or a enamel dentine fracture. If this is the case, then you would also restore the broken part with a composite restoration or a ceramic bonded restoration. For the next type of injuries is a subluxation injury. Uh, the subluxation, it's injury of the tooth supporting structures as well, like the concussion. But in this case, and not like the concussion, you will find abnormal loosening of the tooth, but there will be no displacement of the tooth. You will have a tooth with positive percussion testing. It's tender to palpation. There is a gingival sulcus bleeding, like you can see in here. There is increased mobility of this tooth, like grade 2 mobility. However, on the X-ray, it will show no signs and symptoms of bone loss or periodontal disease. Also, this case may have a sensitivity test negative due to the transient or permanent pulpal damage. Radiographically, you see most of the cases you will see a normal anatomy. You will not see any bone loss. You will not see any abnormalities. And yeah, of course, patient will report the history of trauma, so you can diagnose such a case and that it's a subluxation injury, and this can explain the abnormal mobility of the tooth. For the treatment of such cases, you apply a flexible splint for up to 2 weeks, and you do a selective occlusal relief to prevent the discomfort of the patient. You do not remove a lot of the tooth enamel. You do not want this patient to end up having a problem later because you completely remove the enamel from the palatal side. If you have a persistent um, occlusal um, problem, like every time the patient close the mouth he have a high spot, um, a repetitive occlusal interference can be a sign that that is not a subluxation injury, that is a extrusive injury, and then in this case you will have to reposition the tooth in its right position, and uh, and then you apply the splint. That's why even if you see everything is fine on the clinical examination, you will have to do radiographic examination as well, because if it is an extrusive injury, you will see that the tooth is a little bit out of the socket, and you will be able to reposition it in the place. This is common in the injury of the lateral incisor, because the lateral incisor is a little bit in a lower level than the central incisor. So if this lateral incisor had an extrusive injury and it became at the same level of the central incisor, you may not notice it in the clinical examination, but you will clearly see it on the radiographic examination. For the prognosis of such cases as concussion, pulp necrosis may occur due to the injury of the blood vessels at the apex, and yeah, it's a greater probability that this happen and that later on the patient will need a root canal treatment. You follow up the case for 4 weeks, 6 to 8 weeks, 6 months, 1 year, at any point if signs and symptoms of pulp necrosis or periapical ptosis are noted, then you have to start root canal treatment. Here we reached the extrusive luxation that I was talking about in the previous slide as well, to differentiate between the extrusive luxation and the subluxation. In the extrusive luxation, there is a partial displacement of the tooth axially from the socket. There is a partial avulsion, and the periodontal ligament is usually torn in this case. If you can see here, the tooth apex is not at the lowest point in the socket, it's a little bit in a higher position. And here in such a case, you clearly can see that this tooth is in a lower position than the other central incisor, but and also here the lateral incisor. But if it was not so severe, you will still see it in the radiographic examination. You will see that the tooth apex is not at the lowest point of the socket. And for the treatment of this case, you will have to reposition the tooth with a slow and steady apical pressure, apply a flexible splint for 2 weeks, and reassure or make sure that the tooth is back in place before sending the patient home, because if it's not in place, the healing will occur at this position. In case of necrosis, which is not rare in such cases, it is the most likely prognosis to happen for such cases due to the disturbance of the apical blood vessels. So in such case, you will have to do a root canal treatment as well. And in these cases, there is a risk of pulp necrosis and also a risk of pulp canal obliteration and crown discoloration to happen. So you may need to follow up the case up to 5 years so that if any of these changes happened at any time point, you would be able to um, interfere. For example, here is a patient with a history of trauma from 15 years, and you can see here the apical pathosis, but you cannot see any canal because the root canal treatment was not done at the time it should have been done in. And now it's extremely difficult to find the canal and do a root canal treatment to help the healing of this periapical pathosis. In some cases, complete canal obliteration can happen, and the only option would be is a surgical option of the root resection and a retrograde filling if any canal is visible. Also, crown discoloration is not rare in such cases, and in cases of crown discoloration, you may discuss with the patient is there options that can be either an internal bleaching or an aesthetic ceramic bonded restoration like a porcelain veneer or an emax veneer or even a crown if there is a fracture in the crown, then you may also think about restoring this tooth with a crown. Usually, a single crown in the aesthetic zone is not very easy, but it's not impossible. So now we reach the lateral luxation injuries, and by lateral luxation, I mean it's a displacement of a tooth in a direction other than axial. It's in a lateral direction, either buccal or palatal direction. The periodontal ligament is usually torn, and um, the fracture of the supporting alveolar bone can happen. Clinically, you will see the tooth that is appearing palatally or labially displaced. Palatal displacement is the most common, and the labial is less usual to happen. Palatal displacement is due to the application of a force from a front direction, like being struck with something or being hit by um, by someone or something. So this result in the complete displacement of the crown or the whole tooth into a labial direction, but the root is moving in a labial direction, and this results in the fracture of the alveolar bone. For the radiograph, you will, in an eccentric radiograph, you may not be able to see it in an 90-degree angle radiograph. In an eccentric radiograph, you may be able to see a widening of the periodontal membrane space in some parts and not in the whole surface of the root. For the treatment of this case, you need to reposition the tooth in the socket, and in case that you cannot put the tooth back in place, you may have to think about the position of the tooth now. It may have a bony lock now, here in this position. If you apply a force from this direction, it will result in moving the root against the bone. But you may need to move the tooth in a coronal position and then apply a lateral force to have the tooth back in position and the alveolar bone back in position. After repositioning the tooth, you splint the tooth with a flexible splint for 2 to 4 weeks. You may need to splint it for up to 4 weeks because of the bone fracture. Because as long as the tooth is splinted, then it's not moving, then it's not disrupting the healing of the bone fracture. The necrosis of the pulp is most likely to happen, so you will need to do a root canal treatment if the tooth develop pulp necrosis. For the prognosis, as I said, the pulp necrosis is not a rare consequence, and pulp canal obliteration can also happen if you did not do the root canal treatment on the right time. Also, the root resorption may occur, but it's less likely to happen. For the follow-up, you follow up the case after 4 weeks, after 8 weeks, after 6 months. That's every 2 months nearly in the first 6 months, then after 1 year, and then once yearly till 5 years. At any point, if you find out that the tooth is developing signs and symptoms of apical pathosis or pulpal necrosis, you will have to do the root canal treatment, because later on, after the complete canal obliteration, it is extremely difficult to do this. So here again, to describe to how to reposition the tooth, you may need a forceps to hold the tooth and carefully pull it into a down position, then apply the lateral force to replace the tooth in position. Now we reach the intrusive luxations, and the intrusive luxation is apical displacement of the tooth into the alveolar bone. The tooth is driven into the socket. It's compressing the periodontal ligament and usually cause crashing fracture of the alveolar socket. For the clinical picture, you will see the tooth that appears either shortened or even missing. You will look clinically and you will see like an erupting tooth. However, this tooth was before was nearly like 4 millimeter visible in the mouse. Now it's completely down, completely hidden, like erupted tooth. It may appear missing. You may not be able to see it. You see it only in the X-ray. It's immobile in case of if being in the oral cavity, but in a short position, it will be immobile. And Palpation, it will not be tender. Percussion test gives a high metallic ankylosing sound, and sensitivity test will have a negative result. The percussion test is extremely important. When you do the percussion test, you do the percussion test on this tooth and on a control tooth, and you will clearly hear the difference of the sound in a control tooth and on this tooth. For the treatment of such cases, in case of immature teeth with incomplete root formation, um, you would allow the eruption to happen without intervention. And if no movement happened within few weeks, then you would initiate an orthodontic repositioning. If the tooth is intruded more than 7 mm, then the surgical repositioning or the orthodontic repositioning is indicated. For the mature teeth, you will also allow the eruption without intervention, but if the tooth is intruded less than 3 mm, and if there is no movement after 2 to 4 weeks, no sign, no eruption, then you will reposition the tooth either surgically or orthodontically, because if you leave it in this situation, then the ankylosis is most likely to happen. If the tooth is intruded beyond 7 mm, reposition surgically, and if the tooth if and then you would have to do a root canal treatment using calcium hydroxide as an intracanal medication is recommended, and um, the treatment should begin within 2 to 3 weeks after the surgery. You would After the surgical repositioning, you would also would like to use a flexible splint for up to 4 weeks, just to fix the tooth in the new position and give an give a chance to the apical fracture, the crushing fracture of the alveolar socket to heal. If you remove the splint before, resulting from the stimulation of the tooth, the alveolar fracture may um, not heal properly. For the prognosis of teeth with intrusive luxation, in mature permanent teeth with closed apex, there is a considerable risk of pulp necrosis, pulp canal obliteration, and progressive root resorption. That's why if you use calcium hydroxide as an intracanal medication, it may help a little bit on the root resorption. And if you started the root canal treatment in early enough, then you will not have a problem, or you will not be afraid because of the pulp canal obliteration. In immature permanent teeth that are allowed to reposition spontaneously, they demonstrate the lowest risk of healing complications. They are they are the most uh, they are the teeth that heal the most and they show the best results. In the teeth with extent of intrusion 7 millimeter or greater and adjacent intruded teeth has a negative influence on healing. That's another factor that can affect the healing. If the intrusion is 7 millimeter or more, and if there is not only one tooth but more than one adjacent tooth intruded at the same time, this would be worse than only one tooth intruded. You follow up the case in 2 weeks, 4 weeks, 8 weeks, 6 months, 1 year, and at any point if there is change in the state of pulp, periapical, or um, any signs and symptoms, then you do the suitable treatment. Now for the real emergency to deal with. And it's the last one. I hope you are not sleeping by now because now it's the real deal. It's the real emergencies that you deal with in here, which is avulsion, the complete displacement of the tooth out of the socket, or the complete loss of the tooth. The periodontal ligament is completely torn, and you will have to react fast because you don't have much time in such a case. The clinical picture, yeah, it's clear. You will have a patient coming to you with an empty socket and the tooth in hand, and radiographic examination will show an empty socket. To this is to make sure that's an avulsion case and not um, an intrusion where the complete tooth is missing and it's only intruded inside the alveolus. The patient may come and say he cannot find the tooth and the tooth is intruded into the alveolus. So for the treatment of case uh, of of avulsion, you would have to differentiate between two situations. You will ask the patient, when did this happen and what did you do later on? If the tooth remained out of the mouth dry, which means it was not kept in a preserving medium, if the dry time was more than 60 minutes, then the prognosis is the worst in this case. If the tooth is lost and replanted immediately after the avulsion, the prognosis is the best in this case. For a dry time less than 60 minutes, it's still fair prognosis. So, if you have the situation that you are dealing with a mature tooth with complete root, and the tooth was out of the mouth for less than 60 minutes without any preserving medium, then you would soak the tooth in saline. You would clean the root surface and apical foramen with stream of saline and then soak the tooth in saline, removing the contamination by dead cells from the root surface. After this, you will administer the local anesthesia. you will irrigate the socket with saline. You will examine the alveolar socket, and if there is a fracture of the socket wall, you will try to reposition it with a suitable instrument, with a curette, or pushing it very carefully with a condenser or any other instrument. Then you will replant the tooth slowly with slight pressure. Do not use any force while replacing the tooth. Then if you have any gingival lacerations, you will suture it. After this, you will verify the normal position of the replanted tooth, both clinically and radiographically. If everything is okay and the tooth is in place, you will apply a flexible splint for 2 weeks. Research found out that the administration of systematic antibiotics like tetracycline twice per day for 7 days at appropriate dose for the patient age and weight is can result in a good healing, especially if the tooth was infected by something because of its fall on the ground. If the patient is too young and tetracycline, due to the risk of discoloration of permanent teeth, can happen, then you would shift to penicillin V or amoxicillin. And if the avulsed tooth has been in contact with soil, then you would refer the patient to a physician for a tetanus booster. Then you can start the root canal treatment 7 to 10 days later. This means you will start the root canal treatment before the removal of the splint. You splint the tooth for 2 weeks and you start the root canal treatment after 1 week. If the dry time is more than 60 minutes, then you would if the dry time was less than 60 minutes, you will never touch the root. You will hold the tooth from the crown. If the dry time is more than 60 minutes, and you will have to remove the attached periodontal ligament tissue, because by this time there is a clear evidence that there is no viable periodontal ligament cells on the root surface, and it will cause a problem other than benefit if you leave these cells attached to the root surface. When the tooth has been out of the oral cavity in a dry environment for greater than 60 minutes, then the periodontal ligament has no chance of survival. And if such a tooth is replanted, it's likely to undergo osseous replacement resorption. And over time, the tooth will become ankylosed and ultimately will be lost. So for this reason, you would remove any attached periodontal ligament to the root surface. You can also start the root canal treatment immediately out of the patient's mouth, and you can finish it out of the patient's mouth before replanting the tooth, as long as you will not take like another hour to do the root canal treatment. Or you may do it 7 to 10 days later. You would Then soak the tooth or the root in a 2% sodium fluoride solution for 20 minutes because there is an evidence that fluoride soaking will delay but not prevent the ankylosis. This is because the fluoroapatite crystals is more resistant to ankylosis than the hydroxyapatite. When the teeth are soaked in fluoride before replantation, it has been shown to reduce significantly the risk of the resorption after a follow-up of 5 years. And honestly, despite all these recommendations, the teeth that have been out of the oral cavity for greater than 60 minutes with dry storage have a poor prognosis and will not survive long term. But anyway, you would do this, you will soak it in a sodium fluoride for 20 minutes, apply anesthesia, wash the socket with saline, examine the socket, replant the tooth carefully with no force, suture any gingival restoration, verify the position clinically and radiographically, and then you will stabilize the tooth for 4 weeks, not only 2 weeks, like if the dry time was less than 60 minutes. You will stabilize it for 4 weeks. You would prescribe systemic antibiotic, tetracycline or penicillin B or amoxicillin based on the weight of the age and weight of the patient. You can adjust the dose. And if the tooth was in contact with soil, then you would refer your patient for a tetanus booster if the tetanus coverage is uncertain. And usually you will need a tetanus booster every 10 years. So if it was at the end of this time, like 8 years, and the last antibody titer showed compromised results, then a booster dose will not be it's actually advised in such a case. Now we will talk about the treatment of avulsion in immature teeth. So in immature teeth, unlike the mature teeth, you have no complete root formation. You will start like managing the mature teeth. You will soak the tooth in saline. You will clean the root surface in the apical foramen with saline. You will here apply topically an antibiotic such as tetracycline, because topical application of antibiotic has been shown to enhance the chances of revascularization of the pulp and can be considered, if available, so you would use a 1 milligram of tetracycline solution in 20 milliliter of saline to treat the root. You will soak the tooth in this solution for 5 minutes, and then you will administer the anesthesia. Would wash the socket with saline, examine the socket, and if there is a fracture of the socket wall, you will reposition it in the right position. Then you will irrigate the socket with saline, replant the tooth slowly with slight apical pressure. You will suture the gingival lacerations, verify the normal positions with clinical examination and radiographic examinations, and splint the tooth with a flexible splint for 2 weeks. Prescribe antibiotics, tetracycline, penicillin V, and amoxicillin depending on the age and weight of the patient. You can adjust the dose, and you will prescribe tetanus booster in case of contact with soil. But in this case, you will not start a root canal treatment because this tooth has a good chance for revascularization. You will follow up the tooth. If the tooth started to show signs and symptoms of pulp necrosis, then you may start the apical position. Then you may start the root canal treatment. If the dry time was more than 60 minutes, it's nearly the same as managing the maturity. The only difference is that you will do the root canal treatment outside of the patient mouth or inside the patient mouth, but using an MTA apical plug technique. And in this case, the revascularization is less likely to happen. However, you may consider using the revascularization protocol even in a necrotic pulp case. So in the recommendation of the International Association of Traumatology, it's recommended to do the root canal treatment. However, I would do the revascularization procedure even if the tooth have been out for more than 60 minutes, because if it didn't work, I still have the possibility to do an MTA apical plug even after replanting the tooth in place. Another thing that may happen is that the patient comes with already repositioning the tooth in place. So he lost his tooth, he picked up the tooth, he cleaned it, and he put it back in place. Then you would not take the tooth out. You will leave the tooth in place and clean the area with chlorhexidine. You will verify the position with X-ray and clinically, and if an adjustment is needed, then you would do it. Flexible splint for 2 weeks, antibiotics, and tetanus booster. And the difference between immature teeth and mature teeth is that in mature teeth you will start the root canal treatment, but in immature teeth you would leave it for the revascularization. But signs and symptoms of necrosis and happens, and you would have to do a root canal treatment for this tooth. Something to consider while doing the root canal treatment: you will be having a splint connecting the tooth to the two adjacent teeth. So how will you be able to apply the rubber dam to have the proper isolation? You can do this with what we call a split dam technique. Is that you isolate more than one tooth, you place a clamp on one of the adjacent teeth, you connect the pores that you make for each teeth, you cut them with a scissor, and you can place also another clamp on the other tooth in here, and you can cover this area, you cover the gums with liquidam or any other sealing material, just to avoid the application of the clamp or putting a lot of force on the healing tooth. For the prognosis of the avulsed tooth, as I said, its best prognosis is if the tooth is replanted immediately. And these tooths are having the risk of developing pulp necrosis
root resorption and ankylosis. As you see here in this picture, ankylosis is happening and replacement root resorption is happening. You can see here the tooth structure is completely replaced with bone. For the storage medium to store the tooth so that you can advise the patient to store the tooth in the case of the avulsion, you may tell them to use a Viaspan. However, this is the best thing to use to store the tooth because this is actually the liquid that's used to transfer organs, and it is provided in a safe tooth kit. It's provided in the form of a box that uh, it's called safe tooth, and you can use it as a transfer medium to transfer the tooth. But in case the patient is outside and has no chance to get the Viaspan or the Hank buffered salt solution, which is the second best to use, the patient can easily use egg white or cold milk, or place the tooth under the tongue or in the buccal vestibule, or use it or put it in physiological saline or in water. Water is the least favorable because of the low osmolarity, um, but because of the low osmolarity in water had an adverse effect on the periodontal ligament healing, but it's still a better choice than storing the tooth in a dry environment. Also, for the types of splints, I have been saying flexible splint most of the time. So flexible splint, I mean with it to use something like Rebond from Care, or to use a titanium trauma splint. These splints allow a little bit of movement, and they they can result in better prognosis. For the resin splint or the wire composite splint, you can still use it, but the current evidence supports the short-term non-rigid splints for splinting of luxated avulsed root fractured teeth. So you will not leave the splint more than 2 weeks unless it's needed, like in the case of a root fracture in the cervical position. And in the literature, it's found out that the flexible splints result in a physiologic stimulation to the periodontal tissues and supporting tissues that can promote the healing better than the fixed splints. At the end, I would like to say that what we learn with pleasure, we never forget. So if you like dentistry, then you will be learning with pleasure, and then you will never forget how to manage something, and then you will be extraordinary doctors. And at last, I would like to send my greetings to you from Bonn. It's nearly the same picture as what you see now, what I'm seeing from my window in here. And yeah, I came to the end of my presentation, so please ask me any questions if you have. Thank you very much.
Thank you very much, doctor. We have not yet received any questions, so we will wait a few minutes to see whether there are any. I would like to thank you personally for joining these webinars of 2017. We really appreciate your effort, and I believe it is really a tremendous, huge amount of information that you have just handed towards us right now. So I would like to thank you. And I definitely agree that what we learn with pleasure, we never forget. So thank you very much.
Welcome.
There are no questions so far. I wanted to ask you about the flexible splint, but you have already answered my question. So
Yeah, you can use a Rebond or the TTS titanium trauma splint. They are by research shown to be the most, like, they provide the flexibility, still the rigidity needed to support, but they are flexible to provide the physiological stimulation for proper healing.
okay. And then you also mentioned that they can stay up to 4 months. Is that it? Can a flexible splint stay up to 4 months as well?
Yeah, but in case it's depending on the patient's use, but
Yeah, okay.
in case it's bonded with composite restoration and it can be debonded, but in case it's debonded, then you inform the patient, if it's debonded, please come immediately and you rebond it.
Okay, thank you.
For the questions, will the people write it on the YouTube comments, or they send how they send the
Yes.
questions?
They are more than free to ask any kind of questions through the live chat on YouTube. And but throughout the webinar, they have been just saying that everything is great and that they have no questions and everything is fine. So there's one question maybe, but it's not really specific. It's from Peperim Rivera, and he's asking about, please comment Valjean Tra, but he did not continue with the sentence. So if you...
Avulsion, sorry, I didn't.
Avulsion TRA. Treatment or... Oh, okay. Treatment in primary teeth. But you have already mentioned it, so...
For the, yeah, as I said, if we will go back in primary teeth, the management of avulsion is depending on the dry time. If the dry time is less than 60 minutes, then you would do this procedure, and then you will not do a root canal treatment because you have a good chance of revascularization. Revascularization, I think it will be discussed later on in other webinars with IADS, but simply that the cells from the apical papilla and the remnants of cells inside the pulp will start to divide and migrate from the apical part to the root canal, and they will start a healing process of the pulp, and the root formation will continue, and the pulp structure will be intact. If the dry time is more than 60 minutes, and because of the the damage that would happen to the periodontal ligament space, so not only the pulp is affected, but also the root is affected, and the root resorption is more likely to happen, and ankylosis is more likely to happen. So in this case, you would either do a root canal treatment, or I would prefer to follow the revascularization protocol presented by Banks and Troop in 2004 by initiating bleeding and disinfecting the root canal with a tri-antibiotic paste, and having an MTA coronal barrier just before going for an MTA apical plug. If this does not work, then I have always the possibility to place an MTA apical plug I'm not sure if you know what I mean by MTA apical plug, but here that's a picture of what I mean by MTA apical plug. You place MTA or biodentine into the apex of the tooth and you fill the rest of the tooth with gutta percha. So yeah, that's how you manage the avulsion in immature teeth. Nothing more. You splint it for 4 weeks and you hope that the healing will happen. That's it.
Oh, thank you for the explanation. There is question. He was actually asking about baby teeth.
Uh, yeah, for the
Yeah.
primary dentition, it's completely different, especially in the avulsion. If the avulsion happened in a primary dentition, then it's contraindicated to replace the tooth in its position because you may cause an injury to the permanent tooth waiting under this. So the management of primary dentition is completely different. That's why I was stressing from the beginning that this is for the management of permanent dentition. For the management of primary dentition, that needs another lecture because it's nearly completely different. Because there are some other factors um, to be noted, and there are some other um, let's say situations that can affect your decision, like if this tooth is lost, how long it's still for the permanent successor to come, and what is the possibility of having a permanent successor, what's the possibility of causing a damage to the permanent successor while trying to retain this primary tooth. So a management of primary teeth is completely different, and yeah, if we would discuss it now, it will take another 1 hour or something, and I think it's not the case now. We can have another webinar for the management of primary teeth.
Okay, we'll definitely try to schedule that one as well. There is one more question and comment from Zarui. She's thanking you for the webinar, and she's asking whether we can use calcium hydroxide for final root filling in these cases.
The problem with calcium hydroxide is that you would use it to perform an epexification or in epexogenesis. You would use it as a material that will stimulate the formation of a hard tissue barrier, or that will stimulate the complete formation of the root. But calcium hydroxide itself is soluble in water, so it will be soluble in body fluids, and it can never give a hermetic apical seal, so you cannot use it as a definitive filling material. You would place it inside the root canal, but you will have to change it from time to time, because otherwise it will completely dissolve. It will be completely dissolved in the body fluids over the time, and you will end up having an empty canal that will maybe re-invaded with bacteria and redevelop apical pathosis. So you would either follow the revascularization protocol by disinfecting the root canal with triantibiotic paste, inducing the bleeding inside the canal, hoping that some cells from apical papilla will come and migrate in the tooth, and close it coronally with an MTA or biodentine, and hope that the tooth that the root formation will continue. If this does not work, then you will have to place an MTA or a biodentine apically in the form of apical plug and fill the rest of the canal with catapertia, or if the tooth needs to be crowned and a post needs to be bonded, then you would not be able to do a revascularization treatment. Then you would do the apical plug and bond a fiber post in the rest of the canal, do a core buildup, and have a crown. That's only in the case of avulsion and crown fracture. Avulsion associated with a crown fracture.
Thank you. There is one more question from Peperin. He's asking, I believe it was back to that baby teeth avulsion treatment. He was asking what the tetracycline solution soaking for.
The tetracycline is used in the treatment of permanent teeth, as I said. It's a permanent teeth.
As a systematic treatment, right? Not a soaking of a avulsed tooth or
No.
anything.
In case of immature teeth, it was found that soaking the tooth before replanting it in tetracycline solution, in 1 milligram tetracycline in a 20 milligram saline for 5 minutes, it results in a higher probability of revascularization. So you soak the tooth, the immature tooth, in tetracycline to disinfect the root and to prevent the osseous healing or the disintegration of the periodontal cells. So you would stop the ankylose. You would result in you will have a better chance for revascularization to happen, and some kind it will result in a better periodontal healing, because tetracycline is also used in cases of periodontitis, because it can have a positive effect on the periodontal healing.
Thank you. I understand it now perfectly. I hope that Pepperim's questions was he's fine with the answer. And for now, there are no other questions, so I would love to thank you again. And I hope we'll be able to schedule another amazing webinar with you in the future. So thank you again.
Thank you, and have a good evening and a good start in the week tomorrow.
Thank you, you too.